Lateral lumbar interbody fusion is one of the surgical techniques that a surgeon will typically use to perform a spinal fusion where the surgeon will place a device between the bones or between the vertebrae of the spinal column. The surgeon will typically want to choose a technique that allows the surgeon to place the device in the most minimally invasive fashion possible. Sometimes that's a procedure where the surgery is done from the front. That's called an anterior lumbar fusion. Sometimes the surgery is done all from the back. That would be a posterior lumbar fusion. The lateral lumbar interbody fusion is typically done through an approach where we make an incision on the side, on the abdomen, just right above the pelvic bone. In many cases, that is the most minimally invasive approach to get to the discs, typically at L4-5 or above, meaning L3-4 or L2-3. Once the surgeon makes the incision, then there is a series of tubes that go down through the incision onto the lateral or side of the spinal column, typically aiming towards the disc that the surgeon is targeting. Once the device is locked onto the disc, then the disc is completely removed. All of the degenerated disc material is removed from that space. That achieves several things. Number one, it allows the surgeon to take pressure off of nerves that are being compressed, but it also creates a space for the fusion device, or what typically is called a fusion cage. These cages are made either from a plastic material called polyether ether ketone, or now in many cases made from titanium. The device is kind of a rectangular shaped device. It's hollow in the middle. The surgeon will fill that device with bone graft material, and the fusion device will then slide through that tube into the disc space, separating the bones and creating much more space between the bones, like there should be, which also allows for additional pressure to be taken off of the nerves that are being pinched. Once that device is inserted into the space between the bones, then that tube is removed, the incision is closed, and the procedure is over. In some cases, the surgeon may choose to place screws or a plate onto the lateral aspect of the spine for extra stability, or in some cases, the surgeon may make small incisions in the back to place screws and rods for extra stability. In some cases, the lateral interbody fusion may be part of a staged approach, where the surgeon might approach several discs from the front, several discs from the side, and then perform instrumentation and fusion from the back. Typically, this is done for patients who have multi-level degeneration or deformity, such as a significant scoliosis of the spine, and multiple levels of the spine need to be fused. In many cases, I will perform an anterior interbody fusion or ALIF procedure at L5-S1, sometimes L4-5 and L5-S1, and then follow that with a lateral procedure from the side done at the L3-4 and L2-3 levels, and then that will be followed by instrumentation or screws and rods placed sometimes from L2 down to the sacrum or S1 level. Sometimes that fusion will go from T10, which is at about this level, down to the pelvis. And that allows for correction of spinal deformity and for restoration of stability to segments that have become severely degenerated and unstable. Once the surgeon has placed the tube onto the disc from the side and confirmed the positioning with X-ray, at that point the surgeon will completely remove all of the degenerated disc material between the bones. This allows for nerves that are compressed to be decompressed by removing that disc material. It also creates a space between the bones, which allows for placement of the fusion device, and these devices are typically called fusion cages. For instance, this is a device that I use that is made from titanium. It's a hollow device, and we fill that device with bone graft material, and that device will then slide down through the tube into the space between the bones. The device is tapered, and as it goes in, it will separate those bones to create more space. It will also help restore the alignment back to the bones that have gotten out of alignment due to instability and arthritis. Once the cage is in its final position, then the tube is removed and the incision is closed. As far as success rate, the lateral lumbar interbody fusion has a very high success rate for relieving radiating leg pain and sciatica from spinal stenosis and instability of the spine. It can also be very effective at relieving back pain from these degenerative conditions. As far as the risks of the surgery, the risks of the surgery can be broken really into three categories. risks of anesthesia, risk of things that can happen during the procedure itself, and then risk of things that may happen after the surgery. Risks of anesthesia are generally the same with any spinal fusion procedure and not unique to the technique, and those include risks of allergic reaction to medication, possibility of seizures, heart attack, stroke. Even death is a risk from anesthesia, but very unlikely. Obviously, you would need to discuss your individual risk with your physician, the anesthesiologist, potentially your primary care physician or cardiologist. During the operation, there are surgical approach related risks. What that means is what structures are at risk while the surgeon is performing the procedure. So as the surgeon accesses the disc from the side, there are obviously anatomic structures in that area that are potentially at risk. And that includes the kidneys, that includes the tubes that carry urine from the kidneys to the bladder, that includes major blood vessels that travel to and from the heart that are in very close proximity to the spine, as well as other organs such as the intestines and the colon. The surgeon will typically use X-ray guidance to guide the tube onto the disc, and also use nerve monitoring to monitor the nerves that are in that area. Those nerves are called the lumbar plexus. Those are the nerves that exit from the spinal canal. They basically go down into the legs, and the surgeon wants to make sure that those nerves are protected during the surgery to prevent risk of injury. After the surgery, the risks include risk of infection. There's always about a 1% risk of infection after a surgical incision. There's risk of the bone fusion not healing after the surgery, and there's about a 3 to 5% risk of that happening. One thing that patients will commonly experience after this surgery is some temporary pain or numbness in the groin or thigh on the side that the surgeon went in from. The reason for that is that the psoas muscle, which is the muscle that the surgeon has to go through to get to the spine, that muscle basically goes to the groin and allows for flexion of the hip. And so there can be some soreness or numbness in that area after the surgery that typically will last for about 6 weeks, and then in most cases resolves. The surgery typically will take approximately an hour to an hour and a half or up to 2 hours for a one-level procedure, depending on whether or not the surgeon places additional screws or places screws from the back. In many cases, the surgery can be done as an outpatient. Patients don't necessarily have to spend the night in the hospital after this type of surgery. We typically will get patients up the same day of surgery and get them walking and moving. Before patients leave to go home, they can walk, they can climb stairs, they can really sit in whatever position they're comfortable in, they can sleep in whatever position they're comfortable in. Most patients are back to driving themselves and back to the office doing sedentary desk work, usually around 2 weeks after surgery. It does take about 3 months for the bone fusion to get solid enough and stable enough to where we let patients start some physical therapy to work on back strengthening, core strengthening, stretching. And then once patients have gone through usually 3, maybe 4 weeks of physical therapy, I release them to full activity: golf, tennis, exercise, skiing, running, martial arts, basically whatever activity they want to get back to. Once that fusion is solid, then I let them get back to full activities.